This is one presentation which I delivered in AIOS ARC meeting at Lucknow on 12th March, and the topic is intravitreal injections, do's and don'ts. Now I'll be sharing my experience and evolution of my technique since I started using this route of drug delivery, and talking about my experience. I have delivered close to 4,000 intravitreal injections since 2004, and this includes anti-VEGF, antibiotics, and steroids. And patients include diabetic retinopathy, endophthalmitis, retinopathy of prematurity, and I also have some published research work on intravitreal injections. So when looking at do's and don'ts, let's put at this point in a retrospective manner so that we can first of all look at the complications associated with intravitreal injections, and then we can work our way back to the technique so as to eliminate those possible complications. So these are the possible complications as noted in text regarding the issues associated with intravitreal injections. And last four points I have striked off because they are not related to the procedure but rather related to the counseling process. So we remove them, and then we are left with these. And again, if you look at these are also related to post-injection problems, and they are part of the consent and not the procedure itself. So we'll strike them away. So these are the known complications which occur because of intravitreal injections, and we'll deal with them one by one. So the most common issue is pain or foreign body sensation, epiphora, and this is usually due to dry eye because of exposure. So to counteract that, don't put the speculum till you have loaded the anti-VEGF in your syringe and you are just ready to inject. If you do so, the minimal exposure of the globe and an eye which is unattended while you are loading the injection is eliminated, and this excludes possibility of dry eye corneal abrasion infections. Another issue is bleeding. So take care that when you inject, you select a point where the blood vessels are minimal and it is the right place, and this will eliminate subconjunctival bleeds. Talking about vitreous hemorrhage, I have never ever encountered a situation where an intravitreal injection resulted into a vitreous hemorrhage. So that is possible only when you are injecting at a wrong point. This is another complication which can lead to retinal tear and detachment, and this is because usually the injection site is too posterior. And to eliminate this, you can always have correct measurements done when you are selecting the site for injection. Another issue is formation of cataract, and this occurs when the injection site is too posterior, and this also can be eliminated if you have measured correctly. Now, endophthalmitis after an intravitreal injection is a most dreaded complication, and this can be avoided if you have pre-procedure investigations like blood sugar, kidney function test, and hemogram, which will eliminate possibility of immunocompromised state, and so that there is no increased chances of opportunistic infections. Pre-procedure povidone iodine 5% in the conjunctival sac will eliminate possibility of excessive flora being there, and post-procedure hygiene and topical antibiotics to be managed so that there is no chance of post-injection infection. If these things are taken care of, possibility of post-injection endophthalmitis is nearly eliminated. The last issue which remains with us is intraocular pressure elevation, which is usually mentioned in terms of post-injection rise, which is in a long-term follow-up, and this is usually associated with steroids. But here I will add something more. Now this is a published research work on intravitreal injection, and this is about the immediate post-injection rise in intraocular pressure. And we had some issues here which we had studied, and I'm presenting the same here, which will enrich your experience and knowledge about intravitreal injections and things which you can do. Now usually just after the injection we all have noticed that there may be a bleb because of leakage of the fluid from the vitreous cavity from the injection site, and this bleb is something which we usually think that is not a good sign, but we'll dissect this further. So we studied the possibility of this bleb forming by comparing two injection directions or technique. One was direct and perpendicular and other was tunneled. Tunnel means there is some angle at the injection site so that the needle forms an angle to the scleral surface and it is not perpendicular, and this results into formation of a tunnel which is supposedly self-sealing. And we found that the fluid reflex is more common in the straight or perpendicular technique rather than the tunnel technique. And at the same time, the IOP rise were more in the oblique group, and this is understandable because amount of fluid refluxing would neutralize the possibility of intraocular pressure rise. And so the presence of a reflux bleb had a lower IOP rise, and this was a welcome sign, because a rise in IOP is something which causes that discomfort which persists for half an hour to 1 hour in these patients. So we don't want IOP rise. So that means that bleb is good. So our study had a conclusion that tunnel injection technique provides a lower fluid reflux, but if we consider that this is the drug leaking out, then we can also expect that the patients who have had blebs during the injection will have lesser therapeutic effect. But this was not so, which we found in this study, and all the patients, whether they had bleb or no bleb, they all had therapeutic benefit comparable, and there was no increased risk of endophthalmitis when there was a fluid reflux or a bleb formation. So in conclusion, I can safely say that straight technique is a better choice because the IOP rise is lower, although we can have a bleb forming, but still the IOP rise is lower, which is a good part of having a bleb. It is easy to learn, less traumatic and less discomfort to the patient because IOP rise is less, and there is no compromise in the therapeutic effect. At the same time, there is no increased risk of endophthalmitis. So I would say that the bleb, which we may not like, but this is the hero we are looking for. And next time when you inject anti-VEGF, take care of the other issues as mentioned, but also take care that you inject directly, and more so one can also do a pre-injection paracentesis to reduce the IOP further. Thank you.